and 5, 4, 3, 2, 1. And go.
Okay. Welcome. This is Wynn Arias at the NIH, and you are most welcome to the 13th session of the 21st year of a course called Demystifying Medicine, which seeks to bridge the exciting developments in biology and engineering with medicine. Many of our topics have particular interest to somewhat smaller groups of individuals. But today's topic, chronic COVID or long haul COVID, is of interest to everyone, in fact, to the world. The sessions of Demystifying Medicine are held on Tuesdays from 4 to 6, from January 4th to May 3rd. The videocast site is indicated on the slide, as is the site for checking the schedule of the entire course. Those who attend at least 50% of the sessions, all of which are virtual, and pass a final exam, which is not very difficult, will receive a certificate. The number 38653 is not today's lottery winner. It's the number for physicians who seek CME credit for attending this course. Now, of considerable importance is that everyone should submit questions during the presentations. And the way to do that is to click on the Send Live Feedback on the videocast display on your site. Please note that all the previous sessions from the very beginning, 20 years ago, are archived and are available using the website indicated on the slide. If anybody has any additional questions, please get in touch with me. Next slide, please. Next slide, please. Okay, so as I mentioned, this is really a course in bridge building. And in this case today, we are bridging the entire area of of chronic COVID. Particularly, I would emphasize the neurologic and the mental disease aspects of it. And that's what these two gentlemen on the catwalk are discussing. They are bridging between Brooklyn and New York, and likewise, we will be bridging to learn more about chronic COVID and where we stand. The next slide. Now, what is post-COVID problems anyway? And this slide lists a bunch of them, and you're going to hear more discussion and detail of them. They range from respiratory, shortness of breath, cough, mental, memory, concentration, sleep problems, cardiovascular, palpitations, loss of smell or taste, which was recognized very early in the course of the disease. And of course, substantial increase in depression and anxiety brought about by the isolation that is imposed by the viral infection, and fever and dizziness. And then there are rare true organ damages where pathology has been shown. The rare multi-system inflammatory syndrome, Kawasaki's, mainly in very young children and young adults, cardiovascular, kidney, clot formation, strokes, and the Guillain-Barré syndrome. All have occurred, are rare, and whether they are direct results of the COVID virus infection is one of the topics that will be discussed today. The next slide, please. An artist captured the entire panorama. This is from the cover of Cell magazine, March 3rd. And in the rear view mirror at the bottom of the slide, is what we've passed, that is the virus. But what's ahead is a long and complicated road, and it's not clear when and how it reaches the actual sunshine. And it's this area of uncertainty and challenge that will be discussed today. And we are most fortunate, next slide, please, to have two individuals who have played and are playing a major role in trying to unravel the problems of chronic COVID, particularly from the standpoint of neurology and mental health. So each is a director of the National Institute and the National Institutes of Health. Our first speaker, Josh Gordan, has his degrees, MD and PhD, worked for many years at Columbia University and the Psychiatric Institute associated with it, and came in 2016 to be the director of the National Institute of Mental Health, which you should know oversees over $2 billion in research and public outreach on the pandemic's effect on mental health. So Josh is a member of the National Academy of Medicine, and his own individual research is in applying neuroscience techniques from in vivo imaging, behavioral recordings, optogenetics. Use these to study in patients schizophrenia, anxiety, and of course, depression. So Dr. Gordan will be our first speaker. And then our second speaker is Walter Koroshetz, who trained in neurology and neurosciences, largely at Harvard, where he was at the Massachusetts General Hospital for many years, came to the NIH as a deputy director of the National Institute of Neurologic Diseases. And in 2015, he was made the director. That institute oversees in excess of $2.5 billion for research in neurologic diseases. It is also a primary funder of COVID-19 research due to SARS-CoV-2 virus and its effect on the brain and the nervous system. Walter is also a member of the National Academy of Medicine, and his individual research is on excitotoxicity as a cause of neuronal cell death. So Dr. Gordan will speak first, to be followed by Dr. Koroshetz. We encourage you to submit questions during these presentations, and then they will be discussed in a Q&A period at the conclusion of Dr. Koroshetz's talk. So please, Dr. Gordan.
Thanks, Win. I appreciate the introduction, and I was looking forward to speaking with you all about COVID-19 and mental health. And I titled this The Short and the Long of It. Hopefully it'll be a little bit on the shorter side so that, actually, wait, is it actually working? I don't think it is. So that I leave plenty of time for Walter. Okay, now you should be seeing, there you go. Seeing it now?
Yes.
Great, okay. And just if everyone can mute if they're not speaking, all the panelists, there was a little background noise, but I think it's gone, so that's good. All right, why talk? Well, first, I have no disclosures, and the objectives are listed here to understand the mental health impacts of the pandemic and to understand the bidirectional relationship between COVID-19 and mental health. And if we're going to talk about long COVID or chronic COVID or the post-acute sequelae of COVID infection, in the context of mental illness, it's really important to understand that long COVID is not taking place in a vacuum. It's taking place in the context of tremendous mental health impacts of the pandemic on the general population, as well as impacts of the pandemic on those with pre-existing mental illnesses. And those complicate our ability to study the persistent mental health effects of COVID infection itself. So I'll take you through those first 2 points before we actually get into the discussion of long COVID per se. So what have been the impacts of the pandemic on the general population? The hazard of working at home, can't stop the phone from ringing. First and foremost, we know a lot about what to expect in the context of pandemics, disasters, and other emergencies from really decades of research. Most who are exposed to traumatic experiences will have some initial symptoms, and for most of those symptoms will improve with time. Some, though, will have long-term or chronic experiences with mental illness in the aftermath of such an emergency. And lots of factors predispose towards those longer-term or chronic experiences, including social inequities, disparities with regard to trauma exposure itself, and subsequent mental health care vulnerability. But one of the strongest factors predicting chronicity and severity is the immediacy of the exposure to the traumatic event, which complicates the interpretation of long COVID. Is long COVID, let's say you have psychiatric symptoms in the aftermath of long COVID, is that due to the traumatic experience of the infection and of being in the hospital and of being separated from loved ones, or is it due directly to a biological consequence of the infection? And we'll talk more about that as time moves on. In addition to these risk factors I've mentioned, there are other individual differences, including a history of prior trauma or mental illness, ongoing stressors, including occupational and financial strain, substance abuse, being female or non-white, and having few social supports. And of course, these individual differences also are interacting, and number one, and number two, may be actually reflective of one or more of the other ones. So the point here is not to try to convince you of individual risk factors, but to say that there's no single variable that determines individual outcomes in the setting of an emergency. And it's quite an emergency we've been facing over the last 2 years. I know I don't have to tell you all. But the reason why we're virtual and not in building 50 right now is shown right here on this graph, which is a graph of the daily cases of COVID over the last 2 years, with the prominent Omicron spike right there in the early 2022. And even early in the pandemic, it was recognized that the pandemic and or the mitigation measures and the economic impacts have had substantial effects on mental health in the general population. The earliest report was in the summer of 2020, taking data through late June of 2020, basically the first spring of the pandemic, showing a doubling in the rate at which US adults reported struggling with mental health or substance use issues across a range of different factors. That increase persisted and actually even rose through the fall of 2020 and into early 2021, with approximately 35 to 40% of Americans self-reporting symptoms of an anxiety or depressive disorder. These are substantially higher numbers than we would expect at baseline. Another indication, a little bit harder data, is an increase in the rates at which individuals were seeking prescription medication or receiving counseling or therapy for mental health symptoms, but all point to the tremendous effects of the pandemic. Now, one could say, oh, maybe it's just mild or moderate symptoms that people are reporting, but in fact, across a broad range of severities, you're seeing more people after COVID than before COVID reporting, in this case, depression symptoms, whether they be classified as non-mild, moderate, moderately severe, or severe. And so we're seeing increases even at the severe end of the spectrum. One piece of good news in this is that we are seeing what we might expect to see, that is cases, the current cases in red of COVID through the course of this case 2020 roughly correspond to peaks and valleys in the case in reports of anxiety and depression. So on the one hand, worsening severity of the pandemic worsens symptoms in the general population. On the other hand, as the pandemic abates, as predicted, we can expect that for most individuals, those symptoms themselves will abate as well. Now, there are some specific issues that we're most concerned about with any epidemic or any traumatic experience. And one of those is the rate of post-traumatic stress disorder. And across a broad range of variables, we can see an increase in the prevalence of post-traumatic stress disorder in the context of pandemics, and this is multiple pandemics, be it SARS, COVID-19, or other pandemics, amounting to about a 0.1 to 0.3 fold increase. So 10 to 30% higher rates of PTSD in the context of pandemics. And as you can see from this particular set of studies from the meta-analysis, that's true for COVID-19 as it was for Ebola and SARS. How do we help prevent the onset of PTSD and other chronic mental health problems in the context of the pandemic? Well, a lot of it is what we have been doing in the context of COVID. We've been trying to meet the immediate needs of people for food, housing, shelter, and clothing. One study, for example, has shown that those in communities who received free groceries or meals compared to those who didn't receive free grocery meals had lower levels of a variety of mental health complaints. Other things that we can do is to practice healthy coping strategies, something NIMH and NIH and the CDC have all been active in promoting, whether that be engaging socially with others, sleeping and eating well, and seeking help when you need it. Practicing healthy coping strategies can reduce the likelihood of chronicity of problems. And finding ways to help others in the context of an emergency promotes a sense of self-efficacy, promotes connectedness, and can forestall the worst effects of traumatic experiences. Now, in addition to the impacts of the pandemic on the general population, the impacts on individuals with pre-existing mental illnesses have, as we might have expected, been significant. But one of the things that was unexpected, or at least not clear that we would see, was revealed actually by our colleague, Nora Volkow, the director of NIDA, and members of her laboratory, who looked at electronic health record data and saw that individuals with mental illnesses had increased rates of contracting COVID-19, of getting the infection early on in the pandemic. This data is from, I think, through the summer of 2020. That included diagnoses as diverse of ADHD, bipolar depression, and schizophrenia. And the odds ratios, the fold increases in the likelihood of contracting COVID-19 if you had, say, schizophrenia or depression, were staggering. Your 10-fold increased risk if you have a serious mental illness compared to if you don't. Moreover, if you have a psychiatric diagnosis, you're more likely to die from COVID than if you do not have a psychiatric diagnosis. And that's especially true for individuals with schizophrenia, who have approximately a 3-fold increase in risk, even after you account for comorbidities that are present in schizophrenia, like heart failure, hypertension, and myocardial infarction and diabetes. So even controlling for these demographic variables which raise your risk for death from COVID, you nonetheless have an increased likelihood of death if you have a serious mental illness like schizophrenia. And that association with mortality has been borne out in a meta-analysis covering a wide range of mental illnesses. And it's especially seen in the studies that included or focused on schizophrenia across a wide range of different localities, with an odds ratio slightly less than that one study in the US would suggest, of around nearly 2. That odds ratio is enhanced if you're a member of a minority class, which are already at increased risk of serious consequences of COVID. For example, African Americans with schizophrenia have about a 2-fold increase in risk compared to whites with schizophrenia of dying from COVID if they get it. There are similar disparities in the prevalence of a wide range of mental health symptoms in the context of the pandemic in the general population as well, pointing to the fact that the pandemic has not been kind. In fact, it's been particularly brutal on minority populations in the United States. What are we doing about it? I could talk a lot about the research that NIMH has supported, but that's not really what we're here to talk about. But I just wanted to mention one because it's sort of relevant to the kinds of interventions we're hoping to test in long COVID. This one award that NIMH gave out, it seeks to understand the role of giving mobile mental health care to individuals at risk for mental health issues in the context of the COVID-19 pandemic. And in particular, it's focused on delivering this care to Black, Latinx, and American Indian individuals. It tests this mobile app that can reduce anxiety and depressive symptoms in the context of COVID-19. And the app includes a number of evidence-based approaches to treating such symptoms, including symptom monitoring, exposure management, which is aimed at post-traumatic stress disorder-like symptoms, as well as education on the stress and coping strategies. So that's just a little bit on the mental health effects of the COVID pandemic and how severe they've been on those with mental illnesses. And as I said, that complicates our ability to look at the persistent mental health effects of the pandemic, but nonetheless, we can do it with the right controls. So early on, actually, this was published in 2021, but it was actually a preprint in the fall of 2020. Early on, it was recognized that there are neurologic and psychiatric outcomes amongst survivors of COVID-19 as late as 6 months after the initial infection. Now, how do you look for increased rates of mood, anxiety, or psychotic disorders in the context of the COVID-19 when you're also seeing increased rates in the general population and increased mental health consequences in the context of the traumatic exposure? Well, the way this particular group led by Paul Harrison tried to do that was compare the rates of such symptoms in individuals hospitalized for COVID-19 compared to the individuals hospitalized for other respiratory tract infections, so other serious hospitalized respiratory tract infections like influenza and the like. And what you can see is even for controlling for those who've been exposed to the trauma of a hospitalization for a respiratory infection, you can see increased rates of mood, anxiety, or psychotic disorders in individuals who were infected with COVID-19 compared to infected with other infectious agents causing respiratory tract infections. And one clue to the etiology of this does suggest that it has something to do with the severity of the illness and the locus of that illness. So if you look at the rates of mood, anxiety, or psychotic disorder symptoms 50 days to 180 days out from infection, and separate individuals with COVID-19 into a hospitalized group here in blue, into an a hospitalized plus encephalopathy group here in the dark red, as compared to a hospitalization alone or matched cohort that didn't receive that didn't have COVID-19, but were hospitalized with or without encephalopathy. You can see that what it seems to be is that COVID-19 plus encephalopathy raises your risk for long-lasting psychiatric symptoms. And that risk continues to increase through the first 6 months after infection with COVID-19. So it does appear that there is a conjoint severity by COVID-19 effect which raises your risk for mental illness symptoms. Now, we cannot definitively point to the biology of COVID-19 like this, but it does strongly implicate the fact that there's something special about COVID-19 compared to other infectious agents, and something special about COVID-19 severe enough to induce encephalopathy that raises your risk for these disorders. I'll just point out that this is not the only study to show this. Here's another study. This is looking at a large number of individuals treated for COVID-19 in the context of the Veterans Administration system, the hospital system. And you can see increased risk of a wide range of psychiatric symptoms, including anxiety disorders, symptoms of anxiety disorders, depressive disorders, and PTSD. In fact, these are hazard ratios to the diagnosis of these differential conditions or the presence in particular of suicidal ideation, with increases in the risk of about 30 to 40-fold. 30 to 40% increases, not 30 to 40-fold. That would be pretty remarkable. Also, in the presence of this large study of electronic health records, they could look at the prescription use of antidepressants, the prescription use or misuse of opioids and other substances, and sleep disorders in that same population all have increased risks in the aftermath of COVID-19 from these EHRs. Now here, we're not showing necessarily controls relative to other respiratory tract infections, but we're just demonstrating that in the context of the pandemic, in those who've been infected compared to those who haven't, we're seeing increases in risk for a wide range of psychiatric symptomatology. And that's reflected here in the overall data from this study, showing about a 50% increase in the likelihood of having any mental health diagnosis treated but with a drug, or any mental health diagnosis treated with either one, a diagnosis, drug, or both. Okay, so with that, I'm going to turn it over to Walter with this brief introduction, and that is that in a collaboration with across a number of different NIH institutes, but really led by Walters Institute, the National Institute of Neurologic Disease and Stroke. The NIH Recover Initiatives, which he'll tell you more about, is seeking to understand chronic COVID and to develop interventions that will reduce its impact. And with that, I'll turn it over to Walter. Thanks for listening, and I'll be happy to take your questions at the end.
Thanks so much, Josh. Just going to share my screen, and as Josh mentioned, I'm going to talk a little bit about what we, maybe it's more about what we don't know about post-acute sequelae of COVID, as opposed to what we do know, and then talk about how NIH is attempting to try and get answers to some of these questions. So the problem is that the condition that is called long COVID now is a symptomatic list of things, and people who have these persistent symptoms after the acute infection tend to have multiple, but not necessarily all. It begs the question of whether there are subsets in this group of folks. The symptoms and the effect of COVID point to potential troubles in multiple different organ systems in the body. So we can't really focus in on any one. We have to look at pretty much all the organ systems and how they might contribute to the persistent symptoms that people have after acute COVID infection. And also I point out that we need to set up to look at how the acute COVID infection, which has affected upwards of 76 million people in the US, are going to affect their future health over time. So those are potential increases or maybe decreases, hopefully, in rare conditions or common conditions. So a lot of questions out there to be studied. What is the prevalence? Well, it kind of depends on how you define it and what your study is set up to do. The best data that I could see is from the UK, where their Office of National Statistics is trying to look seriously at what the prevalence and incidence is. And so if you track symptoms in a group of people and look for symptoms that are persistent after 12 weeks of acute infection, the data you get is that it's about 3% if you're doing a careful tracking. If you're looking on just how people classify themselves, it goes up to 11.7%. In the UK, among those study participants with COVID-19, 5% reported any of the 12 common symptoms 12 to 16 weeks after infection. However, the prevalence of these common symptoms that I showed you on the previous slide is 3.4% in the control group who never had COVID. So you have to be a little bit careful in attributing these very common symptoms to the infection itself. However, if you look at people who have consistently suffered from these symptoms in a continuous period for at least 12 weeks from the infection, then you see the incidence is 3% versus 0.5% in the control group. So this might be the best, gold standard data we have so far. If you go to self-reported long COVID and people have COVID and you ask them, are you feeling well or not, it goes up much higher. The data from the UK showed the prevalence was higher in females, higher in adults 50 to 69. Some studies have shown that maybe it's higher in people a little younger than this. It's always higher in people with pre-existing health conditions, and it's always higher in people who have high viral load at the time of infection or a more severe infection. Seem to have a frozen screen. Oh, no, there we go. Okay. This is a study from the Veterans Administration Electronic Health Records, looking at 153,000 COVID positive subjects, 5.86 million controls. And what you see on the slide is the green is people who are never hospitalized and their risk of stroke, TIA. This is just the cardiovascular side of things. The red is people who are in the hospital, didn't really require ICU level care, and the purple are the people who required ICU level care. And you can see that on many things, even if you didn't go in the hospital, there was an increased risk of these cardiovascular stroke complications at this, I think this was out beyond 30 days, going out to about 6 months after the acute infection. So a sign here that there's even something going on if people weren't hospitalized, but clearly those people in the hospital have greater risk for these cardiovascular. There's another study of health records out of Boston, looking at 97,000 people who tested positive for COVID, and then looking at who developed a new diagnosis in their electronic health record, starting, I think, like 3 months after their COVID diagnosis, 3 to 6 months after their COVID diagnosis. And then they actually followed it out 6 to 9 months, and they developed scoring that gives you, the strength of the association of these different symptoms with what they call a post-acute sequelae of COVID. And so things like alopecia are very specific. It's a stress-related response, chest pain, palpitations, proteinuria, and fatigue is down here, but at the 6 to 9 months, it goes back up to be second only to trouble with smell and taste. So you can see how things change over time, but there is clearly, unfortunately, in most of these studies, people who have persistent trouble out past 6 months of the acute infection. In general, the curves look like people getting better over the first couple of months, and then there's a slowing down of the improvement around that 6-month period. And that's very concerning, because a lot of these symptoms are what we see in the condition called myalgic encephalomyelitis, chronic fatigue syndrome. And those people often presented with some type of a viral infection and never got better, but they can be sick for decades. So that's really the worst fear, is that thousands, actually a million people could go on to that very tragic condition, unless we understand how to prevent that, or if this is somehow going to peter out over a longer period of time. Now, what's at the bottom of this? We really don't know what the biological drivers are. I'm going to talk to you about 3 major hypotheses. One is that there's a disturbance in the immune system that occurs during COVID, and that doesn't reset, and that causes persistent symptoms. The second one is that there's a autoimmunity that develops due to the surge in the immune response to the virus, with the immune response then overspilling and attacking self-antigens, so you get an autoimmune disorder. There are some increases of, say, lupus after COVID, classic autoimmune disorder. And the last one is that there's potential persistent virus in the body that is continuing to stimulate the immune system, so you still have those symptoms that you had when you first got infected. So this is a paper that recently came out in Cell. They looked at 309 patients, and they tried to look at everything they could: single cell multiomics of the white cells, plasma multiomics, symptom surveys, autoantibodies, and RNA-emia, and also viremia due to Epstein-Barr virus. So what they found was that there were in the acute stage, there were 4 things that anticipated you were going to get post-acute sequelae of COVID. And those were type 2 diabetes, a high RNA-emia from your COVID-19 virus, then high viremia due to reactivation of Epstein-Barr virus, and then specific autoantibodies. And I just wanted to mention that Epstein-Barr virus is a virus that infects pretty much all of us. When it causes an illness, it's called infectious mononucleosis. It's mostly teenagers, young 20s who get this infection, but pretty much everybody gets Epstein-Barr virus, and it is persistent in the body. And when you have a major immune challenge, whatever is holding down the Epstein-Barr virus in your body loses its effectiveness, and Epstein-Barr virus starts to replicate. And so this is something that you would see in many different immune insults. Now, the problem with the study is that everybody didn't have the same thing, and then they started to look for different subgroups of patients, and they divided into symptoms, respiratory, neuro, GI symptoms, and then claimed that they could find certain patterns that was more associated with the respiratory than the GI and the neuro. So that, that really has to be validated. You start to drop into subgroup specific characteristics, you run into trouble with multiple comparisons. And so this really has to be looked at. What they found was that there was a particular T cell pattern in those people who developed gastrointestinal symptoms in their post-COVID state. They found that there were immunologic associations between different factors, whether they be cytokines or T cell subsets or autoantibodies. And those associations were pretty tight in the acute stage and maybe at 3 months, but then they separated out by 6 months and didn't really hang together anymore. And so the emphasis was on the idea that the best predictors of whether you get past are going to be from measurements that are made during the acute infection. Of course, that's a problem. If we don't understand that right away, hopefully the acute infections will start dropping out, but it's going to be a lot harder to go backwards from somebody who's 6 months out to try and figure out what is the major driver. So just an example. Here's another example. I think the study was from Switzerland, and it's a small number again, only 175 patients. What they're showing here is that if you get COVID-19, you generally elevate your levels of IG3, and they go up in mild disease, they go up higher in severe disease. But of the groups that develop post-acute sequelae of COVID, and this is all lumped in together, you don't see that same elevation of IG3. And the similar pattern is with IgM. So patients who had both high IgM and high IG3 are less likely to develop post-acute sequelae of COVID. And here you can see the probability of developing PASC depending on your IgM level. But there's an interesting cut depending on whether your IG3 level was low or not. And similarly, looks like very almost identical when you look at IG3, and a cut between those who have high IgM levels or low IgM levels. That combination somehow is interacting. Again, these kind of things have to be validated, and then the numbers are small. And then the question is, are there subsets? Because you can see there's tremendous overlap here, patterns. The next one is a paper that's not yet published, looking at IL-1 beta, IL-6, TNF alpha. So a cytokine trial they claim is associated with post-acute sequelae of COVID-19. It's 258 people after mostly mild infection from a town in Germany. And post-acute sequelae reported in 40% of cases at 6 months. So this is self-reported numbers. Dominantly fatigue, shortness of breath, trouble with concentration. But if they looked at just antibodies, just the number of autoantibodies, you get a big increase. I think in the control group it was 0. So if you have PASS, your chance of developing autoantibodies goes really very high, up to like 30%. If you have no PASS or PASS, they didn't really, if anything, the people without developing post-acute sequelae had higher chance of having autoantibodies than the people who had PASS. So they're not seeing a association there with whether you have autoantibodies or not. Now that begs the question of whether there's specific autoantibodies that are causing the trouble. That's not something that they got into. If you look at the probability of PASS with different cytokine levels, then you can see a fairly significant association with high cytokine levels of TNF alpha, IL-1 beta, and IL-6. And these are often accompanied by lower concentrations of a different subset of cytokines. They also said that developing that getting a vaccine after you're infected did not affect your chance of getting PASS. So there was a story that people who have PASS, they got vaccinated, that they felt better. There's been some studies, it doesn't seem like a strong effect size. These folks didn't see it at all. High percentage of people with COVID-19 have autoantibodies, but no associated with PASS. Broad range of cytokines dysregulated long after infection. So the question is this cytokine pattern something that would make you feel fatigue, have trouble with concentration? That's possible, but needs to be pursued further. And their point was that these cytokines are basically coming from the macrophages that are being activated in the lung during the acute infection. Now this is the next kind of thing that worries me the most, is that there may be evidence that the virus, although your acute infection is over, the virus is still hiding in your body. So we talked a little bit about that with regard to EBV. The question is, could that be true with COVID-19? So this study from Michelle Nussenzweig's lab at Rockefeller basically did intestinal biopsies from asymptomatic individuals at 4 months and revealed persistence of nucleic acids from COVID-19 and immunoreactivity in 7 of 14 people. And then they looked at memory B cell responses over time, and they see the changes that are occurring in people are consistent with continued antigen persistence. So this was the first thing that I've seen that suggested that the virus is still present, still active in the immune system. These were not necessarily PASS patients, though. So the question, so it doesn't get you at PASS, but certainly if the virus is still present, that's going to bring, that as a high driver of the symptoms. Then there's this paper coming out of the NCI group, and autopsies on 44 COVID-19 patients over 7 months following symptom onset, and claiming that SARS-CoV-2 is actually everywhere in the bodies, even those who die with asymptomatic or mild infection, and even at late time periods. They're claiming that the replication is present in multiple pulmonary and extrapulmonary tissues. Early infection, harder to see later, but they claim that it's still there in multiple anatomic sites, including the brain for up to 230 days. That's the latest they looked. And they see very little inflammation or sign of viral cytopathology, except for in the lung. So this is not yet published, but I think it's been accepted. And so this really raises the question about persistent virus. And of course, it would lead to people to think, well, if that's what's driving some of these symptoms, then potentially an antiviral agent may work. The vaccine, doesn't seem to have the effect size by repeating vaccination, but potentially the antivirals could. If we go into the nervous system, then people may have seen this before. Dr. Nath's lab at NINDS Intramural initially showed that there's not a lot of virus that he can find in the nerve cells, but the virus is basically attacks the ACE2 receptor, which is present on endothelial cells that line the blood vessels. So you see blood vessel pathology. You see leakage here in green of dyes coming, blood products, blood proteins that are leaking through the blood-brain barrier out into the brain substance, which shouldn't be there. You see loss of extracellular membrane along blood vessels. This is, I think, the normal, and that was the COVID case. And then you see inflammation that starts to surround these blood vessels, which you would expect to see if there's leak of substances from the bloodstream into the brain substance. And then there's an inflammatory response, which is potentially a driver of some of the neurologic symptoms in the acute COVID case. So if you look at risk factors in the spinal fluid, people who have cognitive trouble after mild COVID, again, very small study, but this one showed that 9 of 13 had oligoclonal bands. So these are immunoglobulin bands in the spinal fluid. So they're bands of immunoglobulins associated with particular antigens. Antigens are not defined, but it's a fairly low prevalence in normal individuals. So this indicates some type of production of antibodies in the central nervous system. In studies of acute COVID cases, there's a lot of brain injury, like we talked about, and blood-brain barrier breakdown. And what you see in any instance like that is a leakage of certain proteins, neurofilament light, glial fibrillary acidic protein, out of the brain into the bloodstream. And these were elevated in the study in the acute phase, but they normalized by 6 months. And they found no correlation between symptoms and these CNS biomarkers of leakage. But there is definitely leakage, so there is evidence of cellular injury in the acute phase with severe illness. Maybe not that surprising. Other studies looking at spinal fluid show T cell activation in the spinal fluid. The cytokine response in the CNS, and the T cells pattern you see in the CNS is actually a little different than what you see in the blood. So there's something particular going on in the nervous system, particularly to the nervous system. And this is another study looking at the injury marker, but also claiming to see pro-inflammatory cytokines in the spinal fluid in patients who have neurologic complications, but that's acute COVID. And what are the problems? Fatigue is certainly the most common, but probably and one of the most disabling. The other one that's most disabling is trouble with concentration. And so this is a study from UK, a really large study where they have these computerized tests of digit word span, rare word definition. Here's the list of them. And they tested 81,000 people, and they looked at people who had COVID before compared to normals. What they see is that there is some deficits that you can measure at this population level in people who've had COVID. It's very small effect size if you had symptoms of COVID but didn't have, really trouble with respiration. If you had shortness of breath, you could stay at home. It's a little worse. If you needed medical assistance at home, your score is actually a little worse than that. If you went to a hospital, not on a ventilator, they're significantly worse. And then on a ventilator, they're the worst. So this is a large population study showing cognitive changes related to COVID, whether or not you went into a hospital, but certainly worse the more severe illnesses. So I think and that theme has been repeated over and over again in the post-acute sequelae of COVID issues. Now, in terms of the central nervous system, we're talking mostly about fatigue, we're talking about sleep troubles, and we're talking about trouble with concentration. In the peripheral nervous system, we're often talking about pain and dysautonomia. And the conditions are thought to come from dysfunction in small nerve fibers. And this is a study from Dr. Nath again at Intramural and Louise Loplander at Mass General, where they evaluated a very, this is not a unbiased group. These are people who had some kind of symptoms of long COVID that got them to see a peripheral nerve doc. But they did find in this group about 57 people had evidence of neuropathy from their symptom checklist, and that their testing was consistent with a small fiber neuropathy. So these are the nerve fibers that don't have myelin around them. They go to the skin. They're basically pain fibers, temperature fibers, primarily. And the suggestion was that this is an infection-triggered immune dysregulation that gives rise to the small fiber neuropathy, very similar to Guillain-Barré, except Guillain-Barré affects mostly myelin. But there are forms of very autoimmune post-infectious conditions where the target is not the myelin, but it's the small fibers, and that's what it looks like we're seeing here. And that will also give you autonomic trouble. This autonomic nerve is also a small fiber nerve. There's actually an interesting study that was published looking at the nerve fibers in the cornea. Where you can see here's the normal COVID and having trouble, and here's somebody with COVID and not having trouble, and you can certainly see a severe abnormality in the small nerve fibers in the cornea in this patient with a small fiber neuropathy. There's an interesting paper that came out that got a lot of press in Nature from the UK, where they have a biobank and they do MRI scans on people in the study, and the study started before COVID. So they actually have MRI scans on people before COVID and after COVID, and they could find changes which are primarily decreases in cortical thickness in different areas of the brain. And most of them are associated with the limbic system, which is significantly associated with the olfactory system. So olfactory tubercle, piriform cortex, left orbital frontal cortex, and maybe even left parahemic gyrus. So all limbic system areas. So they show definite thinning of cortex in these areas. It's pretty clear that that's the case. And the question is why? You might assume, well, it's due to the infection, but there is a caveat here, and that is that if you lose your sense of smell, you see changes in a lot of these same regions. There is a study that had nothing to do with COVID, just looking at people as they got older and they lost their sense of smell, and what were the changes that they saw compared to a normal population. So they didn't even have before and after. So they're seeing things in the same areas, same thinning of cortex, clearly much more robust when you have before and after MRI. So the answer to the question could be that it has nothing to do with infection in the brain at all, or immune response in the brain, but it's all related to having lost your sense of smell and plasticity changes that occur afterwards. Just to mention that people have looked at the vaccination story, and certainly if you have been vaccinated, your chance of getting post-acute sequelae COVID is decreased. So that's what I want to just mention where we are in terms of what the studies are that are out there. And as you can see, there's lots of small studies. They're all claiming to see some associations, potentially interesting with regard to causation, but no causation. So the Recover Initiative is engineered to kind of, at the end of the things, to really give the answers as, if it's possible, we're going to get them through the Recover Initiative. And if that, if a small study or investigator-initiated small group gets together, figures it all out, that'd be fine. We can close it down. But the guess is that this is going to be a hard problem. And one reason I think it's going to be a hard problem is because dealing with chronic fatigue syndrome for years, we haven't made any progress whatsoever. And those people, some of those people are bedbound for decades. So this Recover Initiative is funded to the tune of $1.15 billion by Congress. And the goal is to understand the biology underlying recovery over time from COVID, to identify the risk factors, incidence, and prevalence that gets you distinct subphenotypes of post-acute sequelae of COVID, to study the pathogenesis over time, and to identify interventions to treat and prevent the post-acute sequelae of COVID. It's a national scale to be inclusive, diverse participation, and really broad look at COVID, as opposed to not, taking a particular group and studying them and forgetting about the 7 or 8 other groups that constitute post-acute sequelae of COVID. And it's a large study with 30 hubs around the country, 15 adult cohorts, 2 pregnancy cohorts, 8 pediatric cohorts. And importantly, we have engineered in autopsies on people who have survived COVID to find out what can we see under the microscope in people who are still suffering with post-acute sequelae of COVID versus those who don't. I think if anything's going to give us a quick answer, it's going to come out of the autopsy studies. The other ones, there's so much to look at. We're going to see associations, and we're going to have to drill down on those and discard those that are not causative, and really try and keep working until we find what are the biological drivers. We're also looking at electronic health records, 50 million people, and this is particularly to look over time at changes in public health that are related to the COVID pandemic. We are enrolling up to 40,000 participants. I think at last we just started, and it's like 1,500 so far. Electronic health record studies are ongoing, and the tissue pathology, the autopsy study. And we're just setting up now a system to do clinical trials in people who have post-acute sequelae of COVID. We're really interested now that there's still acute COVID around, to try to recruit people who are acute, and then to follow them over time to see what's different in those people who recover well versus those who don't. And this is the opportunity to do that. As I said, hopefully a year or two later, the pandemic will be over. You're not going to get that opportunity again. And the hope is that we can get into clinical trials. I think in the beginning, they'll be based on symptomatic therapies that would reduce symptoms, like what does it take to improve sleep in people with post-acute sequelae of COVID, or treat their pain, or their autonomic trouble, or their depression or anxiety disorders. They may be just like everybody else's who has those trouble. They might be quite unique, and so getting a symptom attenuation would be the first step in clinical trials. But then, if we understand some of the biological drivers, so for instance, we talked about persistent virus, then antivirals would be, therapy that's designed to get right at the root cause of the trouble. So that's what I wanted to talk about. I think we're embarking on an unbelievably large and well-engineered study, and it certainly has taken time to set it all up, but I think it's going to leave no stone unturned, and hopefully we get answers that are going to help people, hopefully sooner than later. So thanks very much.
Well, thank you very, very much, both of you, for really stimulating and informative presentations. We have a barrage of questions, and I'm going to try and condense some of them. But let me begin by this one, and perhaps either Walter or you, Josh, whoever appropriate, might want to respond, or both of you, or discuss it amongst yourselves. So, Shira submits a message. She says, "This has been fantastic. Thank you. However, in a clinical setting, if the biomarkers are diminishing by 6 months, and evidence suggests that long COVID symptoms can last well beyond 6 months, how do you evaluate neurologic symptoms for cause? For example, if an adolescent patient develops some rare neurologic symptom, or maybe a seizure, approximately 6 weeks following a mild COVID infection, it would seem physicians are more likely to evaluate other sources before they look at COVID when it comes to any aspect of treatment. So are these symptoms then treated differently if COVID is the cause? And I guess underneath it all is, how do you determine whether COVID is the cause or related to the occurrence of neurological symptoms during this period when the biomarkers have diminishing, but various symptoms now appear?
I think first, I'll take a stab at it, and then Walter, if you want to add on. First, you have to distinguish between statistical clinical effects and the biomarkers. So let's take the case that you suggest, or really any case of a symptom or a syndrome that happens after COVID. You have to look at the base rate of that symptom in a similar or control population. And that's why we need a very large study to understand what are the consequences of COVID thereafter. Now, even if you establish that there's a higher rate of seizures in the 6 months after COVID, it's quite possible that it's not due to COVID, it's due to something else. So then you need to do your typical differential diagnosis as a clinician. But nonetheless, if you want to know, could something likely be consequent to COVID, we have to compare the rates of those effects in aftermath of COVID compared to control group. I think for a lot of these things, it's going to be really challenging, especially low base rate conditions. But with a large enough study, we should be able to detect some of it. And the question is, how do you treat it? Walter, as Walter said, right now, all that we can do is treat the symptoms. So in the case of the seizure, you're going to treat with an anti-epileptic if it's indicated, right? And that's what you're going to do. But if we can understand the difference in causality, then we would try to target the mechanism underlying, say, seizures in the aftermath of COVID, which might be different from the mechanisms of other forms of epileptic activity in an adolescent. And then finally, with regard to the biomarkers, I think it's really important to, number one, say we do not know whether the biomarkers will be gone after 6 months at this point. We're talking about very small studies. We're talking about neuroimaging studies, which are notoriously challenging. And we're talking about biomarker studies that don't look at a true mechanism at this point. So I think it's too early to say whether the biomarkers are, quote unquote, diminishing by 6 months. And then in terms of the evidence suggesting that long COVID systems can persist past 6 months, again, Walter showed you the data. They're not terribly convincing, right? We're talking about relatively low rates of symptoms persisting out beyond 6 months if you look in carefully controlled studies. So another reason why we need those large studies. So I think, the answer to all these questions is right now, you treat symptomatically, you try to do a differential diagnosis, and in the future, hopefully we'll understand something about the true prevalence of these consequences and of their mechanism.
Walter, do you want to comment about that?
Well, I think it's a really good question. I think that right now, we're kind of looking under the lamppost. So we have a lot of data from acute infection standpoint. And so what we know is, what we used to say in intensive care research, it all boils down to sick people don't do well. And so I think what we see here is that the worse your infection was, increase your chances of developing persistent trouble later on. And then there are patterns that occur in the acute stage that, again, predict potentially, these are small studies now, but just give them credit, that they predict that you're going to have trouble with post-acute sequelae of COVID. Now, but that doesn't mean that those markers are actually the cause 6 months later. They're just a pattern that was identified acutely, and there's some other driver at the 6 month period that those have then normalized. So the other question is, what else is in that pattern that doesn't go away? And that's going to take some time. So, example of the seizures. So everybody gets autoantibodies after COVID, and that probably is not going to be associated with seizures. But if one of those autoantibodies is an NMDA receptor antibody, you're going to have seizures and you can have psychosis, and that's been seen already in COVID. So I would say what we've seen now is kind of like the cloud, and you have to kind of get into the cloud and see the droplets of moisture, and get more drilled down more into what the causation is. So I wouldn't throw it out, but it's not. I agree with the question. It's not solving our problem. It's just starting to open the door to the research.
There's several questions regarding when individuals are diagnosed with one manifestation or another of chronic COVID. Are they infectious? Are many of them infectious? Are they carrying the virus?
We don't think they're infectious. No.
Are they carrying the virus?
The virus could be present. There might be virus present in some cells in the body. There's no evidence that people are infectious at that time period. Yeah, most of the infection is coming out of respiratory droplets, and these people do not have any virus in their respiratory tracts that you can measure coming out, so they're not infectious at all. That's
another group of questions concerned whether the type of symptomatology associated with chronic COVID has been observed with other coronaviral infections, and others have pointed out that those are very similar to some of the symptoms of infectious mononucleosis, and also influenza. Do you want to dissect out some of those differences as to what we know and don't know? Could they all be part of some common underlying mechanism, or would you just comment about this dilemma? Well,
from a mental illness perspective, I sort of telegraphed that in my presentation, right? I mean, yes, we see increased rates of anxiety and depression and psychosis after hospitalization for COVID, but we see that also after hospitalization for other respiratory tract infections. And there could be biological causes related to the coronaviruses from that, but there also are contributors having to do with, ICU stays, which can cause long-lasting mental health complications as well. So I think a lot of that is, from my perspective, in the mental health area, is unknown at this point. I think the fact that SARS-CoV-2 is new, that COVID-19 is a new illness, raises the possibility that it's special. And we need studies to know how special and how different it really is from other coronaviruses. Walter, do you know about, in terms of looking at the presence of the potential presence of the virus in the brain or its effects on brain cells, whether there's data from other coronaviruses?
Well, we did have the initial SARS epidemic, and then the MERS, and those were, severe respiratory viral infections, and those persons were affected for many months or years with similar symptoms to what you have now, SARS-CoV-2. So there's now that we were surprised because the people with SARS and MERS had, they were very ill, and the expectation, anybody who goes in and develops ARDS is on a respirator, they're looking at, many months to years of recovery after that. So the expectation was that, that was part and parcel of getting so sick. The big surprise with COVID-19 is that we're seeing, those symptoms in people who were never in the hospital, and some people are very mild, some may not have had any symptoms. So initially in the hospitals, there was a rush into intensive care units that you remember, and the hospitals then started to set up these post-ICU clinics for people coming out of the ICUs. And the surprise was that they started filling up with people who never were in the hospital. So that's kind of the unusual feature to this virus, which I think Dr. Fauci mentioned. He's never seen a virus with this wide spectrum of phenotypes, from people who completely normal to people on death's doorstep. And that's seemingly also occurring with the persistence of the symptoms. Although, as we showed many times, the sicker you are, the more likely you're going to have trouble for the long term. Now, the other virus, which acts similarly, is Epstein-Barr virus. So many people, everybody gets Epstein-Barr virus, pretty much. Everybody gets it. Most people don't get sick. Some people get infectious mononucleosis. And remember, those folks, usually young kids, they'll miss a whole semester of school because of their fatigue, and they just can't get back to studying like they did before, moving around. And then they start getting better, maybe even go out a year for some people. And we have studies looking at those folks, because some of those develop chronic fatigue syndrome. So that is the closest precedent that I know of to COVID-19, where it spans completely asymptomatic to an infectious problem that lasts with persistent symptoms. You're not infective after a while, like before, but you have persistent symptoms that can go out many months. And then with a small proportion of those people go on to more chronic trouble. So that would be the precedent in my mind. And Epstein-Barr virus is persistent in your body and your brain. You never actually get rid of it.
Is there a relationship between chronic COVID and vaccination status?
I think, just as I mentioned, if you are vaccinated, chance of getting symptoms that are persistent is much less. The evidence that the vaccine actually makes you better if you've already had, say, long COVID, that's not clear. Doesn't look like a big effect size.
There have been several questions where people have asked about the vaccine and asking, does it cause peripheral neuropathy by targeting the spike protein on endothelial cells and all? Does it damage the vasculature? So do you want to comment about any possible such toxicity of the vaccines?
I think there have been a few cases of Guillain-Barré following the vaccine. but very, very, very rare, and I don't think any more than for other vaccines. Otherwise, I don't think there's any evidence of peripheral nerve damage. I'm not aware of any evidence of vessel damage. There's a low rate of, I think it's myocarditis, right, in young men mostly, very low rate, but that I don't know if that's been ascribed to the vasculature versus the muscle itself.
Yeah, I think, as Josh said, Guillain-Barré, myocarditis, we think that those are autoimmune reactions. And so when you get the vaccine, the whole purpose is to develop this immune response to the virus. But sometimes, and we don't understand why, that can spill over to affect immune response against other antigens in your body. So Guillain-Barré is the one that's best studied, and it has been associated with multiple different vaccines. There was one H1N1 flu vaccine that had increased incidence a couple of years ago, and the studies from the UK again showed that in the vaccines that were delivered through a virus, through the AAV virus, there was an increase in Guillain-Barré due to the vaccine. And in the US, similarly, the FDA last summer put out a notice that they were seeing increased Guillain-Barré in the J&J vaccine, which is AAV mediated. Nobody's seen it in the mRNA vaccines yet. But in the UK study, your risk of getting Guillain-Barré after the vaccine is much less, 5 times less than it is if you get COVID. So still, if you don't want to get Guillain-Barré, the best thing to do is still to get vaccinated. Now, in terms of the small fiber neuropathy with vaccine, there have been cases reported after the vaccine, but there have been cases of absolutely every neurologic condition reported after the vaccine. And in none of them, with the exception of Guillain-Barré, has anybody been able to show what Josh was saying in the first place, that it's out of the ordinary for what you would expect, given the incidence of those conditions. But at the NIH, they are seeing patients who had the vaccine, who have symptoms of usually pain, and they have found small fiber neuropathy. They've been well managed by treatment with steroids or IVIG, but they don't know if it has anything to do with the vaccine or not. Can't really tell for sure. They've looked to see if there's some kind of antibody that cross-reacts with the nerves and the virus, but they haven't seen anything. Haven't been affected like that. So it's hard to know if it's causal or if it's coincidental.
So they've been,
But yeah, with the virus itself, it's been demonstrated that you get small fiber.
there have been several inquiries as to whether there are any animal models of long COVID. The point being that without an animal model, it's going to be that much more difficult to understand what's going on and to develop some forms of therapy. So are there any animal models, and what's the status of that research?
I don't know of any animal models of long COVID. Walter, do you know? There are animal models of COVID infection, and especially in non-human primates, and some have developed some rodent analogs, but I don't know if any of them have studied long-term effects.
I think Josh is right. But I suspect that there are people who are smart enough to do that. And there was a call for grants from the Recover Initiative to understand the pathobiology of long COVID, and that included a call for animal studies. So those have come in, and we got a large number of applications, and hopefully we'll I haven't seen them yet, but hopefully there'll be a few in that space. I think that would be important. Of course, these symptoms that the patients are reporting are a little difficult to do, high throughput screening in animals. We're talking about postural static tachycardia syndrome or muscle pain, sleep trouble.
Yeah.
I think if we go by analog to mental illnesses, I think we need to have biomarkers that we can hang our hat on to be able to study in animals. I think it's going to be really challenging to do some of these things in animal models until you know what to look for. So, for example, if it's borne out that the small vessel pathology is part of it, or if the C fiber neuropathy is part of it, then we can study, C fiber neuropathy in the context of COVID infection in an animal model. But absent some of those biomarkers, it's really hard, as Walter said, to take a symptom-focused approach.
I think we've touched on this, but there have been several specific inquiries as to whether patients who have some form of autoimmune disease, neurological or non-neurological, and then become infected with the virus, do things get worse for their underlying disease, or are these two now unrelated? Do they interact with one another? Do we have experience to comment about that?
Well, I think it's a really good question. I think a lot of people are worried about this. I've been following it from the neuro side of things. So multiple sclerosis is probably the most common one, and there's definitely inflammation of the brain and MS. And with COVID, it's not been. The good news is that we haven't seen, something dramatic occur. Some subtle changes could be there that we haven't seen yet, but not seeing dramatic changes there. I would say maybe Dan Kastner would, talk about this, but there are reports that let me get this right. People who have autoantibodies, even if they're asymptomatic, may have a big change when they get COVID and develop conditions that are new, like lupus or rheumatoid arthritis. Certainly diabetes is potentially a different story. That there is most of the studies are showing that there's more diabetes after COVID. I'm not sure if that's neurologic or not, because in COVID, there's involvement of the blood vessels that perfuse the pancreas, and there's evidence of damage to the pancreas. So it could be vascular damage that gets you to the diabetes. It's also complicated by the fact that, as we saw in the beginning, people with diabetes have more severe COVID and they have more trouble with post-acute sequelae of COVID. So it could also be, again, someone like I was talking about the people who have asymptomatic or antibodies, could have people who have preclinical diabetes or undiagnosed diabetes. They're gonna get worse COVID than others, and so not the COVID that's causing the problem, but it's their diabetes that got them the worst COVID. Dan wants to type in about the autoimmune or immune side of that.
Yeah, Walter, thank you for raising that question. And actually, I don't know of any large enough studies looking at this. Certainly, it makes theoretical sense anyway to think that if somebody has already at least some evidence for autoantibodies or an autoimmune process, that simply having the whatever it might be called adjuvant effect of a viral infection could do that. But I don't know that there's enough data really to make that case at this point.
Earlier in the course, Dr. Holland presented fascinating studies on anti-cytokine, particularly interferon antibodies, as being somewhat neglected pathogenic mechanisms. And here in these studies, including the one that Walter referred to that was in Cell, amongst those autoantibodies or antibodies against some of the cytokines, it's not universal. It's not dramatically separating one group from the other, but you sort of wonder whether there is some commonality involved in those autoantibodies to produce the disease. I guess that's an area of very intensive research now, no?
Yeah, no, I think that's very true. And I think in Recover, we're hoping is to collect biosamples from tens of thousands of people and have them stored so that these kind of things can be explored and hopefully give us answers. If not, maybe if we don't get it right away, some smart person 2 or 3 years from now will go back and figure it out. But but yeah, I think piecing apart what autoantibodies are really driving the trouble, what immune changes are really driving the trouble, I think they're tough questions because there's so many. COVID has such a dramatic effect. Trying to understand what's causative, given everything else, everything that's going on, it's going to be difficult. And that's might be where animal studies will be necessary to do those kind of interventions.
It sounds like another Framingham type study. Is that what you think might be useful?
I think Recover is kind of like a Framingham. That's how Recover was put together. Kind of like a Framingham study with 40,000 people, 50 million electronic health records. So it's a real battleship type of approach to the problem. But that's not going to get you, the killer experiment that says, oh, it's that autoantibody that's causing the trouble. It'll get you associations, and then people have to look at those associations and then, pick apart the pathways they think are really driving the symptoms or the pathology. Without those, you don't know where to start. You have no clue what to begin with. But I think they give you hypotheses to then drill down on.
I think in the previous great pandemics and epidemics, including the 100-year-old pandemic, we didn't know enough to save any tissues or cells, or and even in the Framingham study, although there were some tissues that were saved, nobody was into DNA at that point when that study was started. So if we're going to save thousands of samples today, because we're looking at tomorrow's science and coming up with what may be the answers. At the moment, we're talking about autoantibodies, but we don't know what particularly the systems biologists are going to pull out. Are there plans to actually store what would be suitable samples for almost anything that we can imagine is coming down the pike from the standpoint of science?
Yeah, well, it all depends on what the patients will give us. So everything everything depends on what people will do. So I wanted everybody to have an LP and spinal fluid. That didn't go over well. But I think they should have it, but I had it, it's just not feasible. But yeah, that's the idea, is to, in recover, there's 3 tiers of investigation. And tier 1 is pretty benign, but it's burdensome. Tier 2 is also burdensome because it's driven by the symptoms. What we found is that we should have anticipated this, that most of the people have 7 symptoms. So they trigger 3 or 4 different tier 2 studies, and that's way too much. So we have to figure out, we're right now figuring out how to decrease the burden on the patients. And then the tier 3 studies are the really deep mechanistic ones. And the idea is, yes, everything will be saved. Everything we can get a hold of will be saved. And I think the beauty is that what's happened with the tools in science is that that sometimes you don't need to know what the tool is going to be to save the tissue for it. I guess the best example we have from the brain initiative is that people investigating these different cell types and doing transcriptomics out of the cytoplasm and getting patterns of RNA that define the cell. And then somebody figured out you could get the same thing from the nucleus. And the good news about the nucleus is that the way you do that is you put the brain in a blender. And as somebody said, any experiment that starts when you put the brain in a blender is going to be very robust. So yeah, you can get stuff out of the nucleus, and you get that out of autopsy tissue, human brain tissue, because the nucleus is pretty hardy. So you never know, but yeah, throwing things away will always come back to bite you.
It's just like the liver. That's what I hope. You can't put it in a blender. So we have a series of questions about frequencies of diseases, and maybe both of you would respond. For example, does COVID cause or change the incidence of migraine? Why is ADHD a greater risk for COVID? Are people who are chronically disabled, they seem to be more resilient in terms of being infected from the data that was shown. Yeah, so maybe Josh, do you want to start with those?
Well, let me address the ADHD. It's an easy one. We don't know. It's easier to explain. Well, any serious mental illness, though, is going to impact your ability to adhere to mitigation measures. So that's one possibility, right? So if you have schizophrenia, or depression, or ADHD, you may be, for different reasons, less likely to be able to wear a mask properly, less likely to remember social distancing. Maybe you're much more likely to be employed in a job that doesn't permit you to work from home. So you are more likely to be homeless. So for lots of different reasons, you might be exposed more to COVID. That doesn't explain the mortality differences. The mortality differences, though, may have something to do with the your lower ability to seek or to get care when you seek it. So there's both systemic reasons why individuals with serious mental illness have a harder time accessing medical care. There's also evidence of discrimination against individuals with serious mental illness when they bring up medical complaints. They are less often treated in an evidence-based or appropriate manner. So for all those reasons, regardless of diagnosis, individuals with a serious mental illness are more likely to experience negative outcomes of physical illnesses. Maybe that explains the differences in rates of contracting COVID and of death by COVID. But we don't really know, but that's one possibility. The other question had to do with people with disability, right? Actually, I think I saw that question in the chat earlier. I think the question was, can we learn, in terms of the mitigation measures, which have perhaps contributed to the rising rates of anxiety and depression? Might we learn something about resilience from individuals with disabilities who are subject almost all the time to many of these mitigation measures, at least in terms of, more likely to experience social isolation, difficulty leaving their home, and participating in many aspects of life? I think, I don't know the direct answer to the question in terms of what we can learn from studying such individuals. There are lots of different reasons why people are resilient to stresses and to specific aspects of the pandemic, and we absolutely are studying those resilience factors. Some of them we already knew. They were reflected in the earlier points of my presentation. Many resilience factors actually have to do with your ability to socially connect, and that can be done even if you are shut in the home. Other resilience factors include strong family connections, include having been exposed to hardships in the past and responding to them with that feeling of self-efficacy. Maybe that has something to do with the resilience of people with disabilities who've been able to achieve a certain amount of success in their lives nonetheless. They've learned they have self-efficacy to combat challenges when they're confronted with it. So lots of different things that we can learn from various groups about resilience, and we absolutely are doing that in the context of the pandemic. There was a third question, migraines. I don't know about that. Maybe Walter knows about migraines.
Do you want to comment on migraine?
Right. So headache is one of the pretty common symptoms of people who suffer from long COVID, and those headaches they are migrainous in their characteristics. People who have migraine tend to have worse headaches, worsening of headaches after COVID. And so I think the answer is yes, that the COVID and people with persistent symptoms of COVID are having migraine headaches. It tends to go away 2 or 3 months after the infection in many people, but and migraine is so common, it's hard to know if it's worsening your predisposition versus triggering migraine in somebody who would never have had a migraine.
There's an interesting question of the electronic health record. You mentioned in your slide something like 50 million access to 50 million electronic health records. And so the question is, are those in the country who have grossly inadequate health care and availability of public health facilities and so forth? So now we're talking about truly underprivileged, some minorities, unemployed, all of that. Are they included in the electronic health records that are studied? And are some of the differences that may be observed in the United States and UK or Western Europe or Australia due to the fact that in those countries, everybody is included in an electronic health record? Is this an issue in analyzing the results? What do you think about that?
I'm sure every tool that you get to assess health has its limitations and its strengths. The electronic health records system that we are working with is two of them. One is the NC3, which was set up by NCATS as a COVID surveillance system. That was set up purposefully to get a diverse population of people. And so, and the other one we're working with is the Patient-Centered Outcome Research Institute for CORNET, medical records database, which again I think is pretty is large numbers and has people from diverse backgrounds. Now that being said, that's electronic health records, and so they might be the best you can do, but still the point remains that people with low socioeconomic status are not getting their symptoms into the electronic health records because they're not getting good care and they're not seeing doctors. And so we don't have data on task and demographics. We're going to get it from Recover. If Recover is set up particularly not to be biased. But I could say from talking to the doctors who take care of people in the clinics, the post-acute supply COVID clinics, they're not diverse. It's somebody who has the wherewithal and the means to kind of break into the subspecialty clinics. Most of them now are so full that they're booked for months in advance. And so the bar to get there, I think, puts people of so low socioeconomic status at a real disadvantage. So we do have a problem. I think in the research side of things, we're trying to take care of it. On the healthcare side of things, it's a real problem. Now, I know at HHS, the people who run the federal community health clinics are trying to focus on providing care. I suspect that people who don't frequent physicians, don't get any treatment and their symptoms are never coded anywhere. I think there's probably lots of those folks out there. I think one of the stresses on the healthcare system, because COVID, did actually preferentially have bigger hits against African Americans and Hispanics in this country, who tend to come from areas more commonly low socioeconomic status, that disparity in the acute side, which they got hit worse, is going to flow over to the chronic side too. And that's something that the country has to take to mind and try to correct.
Actually, everything I agree with everything Walter said. There's a misconception actually inherent in that question, and the misconception is that under-resourced healthcare settings might not use healthcare records or might not have as good healthcare records, and actually that is not true. So if you look at, in fact, under-resourced healthcare settings like community clinics and Medicaid clinics, et cetera, they were early adopters in the age of Obamacare. And so the penetration of healthcare records, of electronic healthcare records, is actually less when you look at smaller private practices, et cetera, although everybody uses them now. So I don't think it's an electronic healthcare issue, although it absolutely is an access to healthcare issue. And studies like Recover have to work hard to recruit outside of the normal healthcare settings in order to make sure to recruit a representative group.
Very, very interesting. We have, let's see, here's a question. So Jordan asks, how long does COVID affect liver enzymes? Does it affect the liver enzymes? I personally was not aware of that, but is this an issue?
Frequently, yeah. Frequently, here's 46% of admitted COVID patients with elevated ASTs, 35% elevated ALTs. My understanding, they tend to go down within weeks to months after discharge.
So they go down rather promptly, is that?
Well, over a month.
Yeah. There are also a couple of questions. Diabetes mellitus type 2 is listed as a risk factor, both in severity and also in chronic long haul COVID. What are your thoughts about how does that work? Do we understand what the underlying association means in biological terms, mechanistically?
I think, again, there's a lot of possibilities. And I don't think I'm the right person to answer the question, but I'll throw out a couple of ideas. One is that I understand that fat tissue is enriched in ACE2 receptors. Also, fat tissue is, in some instances, almost like an endocrine organ that stimulates abnormalities that affect other body systems, so-called metabolic syndrome. And one of those is actually inflammation, so that obesity is associated with worsened immune responses to a whole bunch of different conditions. And then there's the diabetes issue, which could be separate from obesity or it could be one of the drivers. Those are the things that I would throw out on the table, but I bet you there's a diabetologist on the call who knows the right answer.
So, Josh, do you have thoughts about that?
Well, the other thing which data could tell us, I just don't know the answer to it, is whether the association with long COVID and diabetes might have to do, sorry, my dog is demanding my attention just now, might have to do with the likelihood of a more severe COVID. So I don't know if you stratify for severity, whether you also see the diabetes association.
There was an interesting question of whether people infected with COVID, the active disease or chronic, lose their circadian rhythms.
Well, I would say that sleep disorders are pretty common in the post-acute sequelae of COVID, and I just recall talking to one doc who said that his patient told him that he forgot how to sleep. So he just would go to bed and have no idea how to sleep, just unable to sleep at all. So there is definitely in some people a very profound trouble with sleep. And I think also the paper in Cell claimed that there were proteins, Bach proteins, that they found an abnormal pattern in people with neurologic task. So I think that's something to pursue. Mm-hmm. And of course, if you're not sleeping, the fatigue is going to be compounded dramatically. And if you're fatigued, then your concentration is going to be affected. So some people, it may be that solving the sleep problem could be very beneficial.
So I guess the last question that we might ask is, how should we prepare for the next post-pandemic?
I mean, in my mind, the most important things we can do are to really understand two phenomena that have nothing directly to do with long COVID, right? One of them is what mitigation measures work and what don't, and what's the relative cost benefit of those mitigation measures. I think there were a lot of different experiments in the United States along those lines, and we hope to learn something from those variants in mitigation measures and their adherence, as well as the effects of those mitigation measures on things like economic effects in school, et cetera. So already we've learned some things, but I think that's one. that'll help us prepare a lot for the next pandemic. The second thing, which also doesn't have much to do with it, is trying to, oh, it just flipped out of my head. So I'm going to hand it over to Walter, and maybe it'll come back when Walter tries to stab at the answer.
Well, I think from an NIH point of view, having been involved in the
I think we,
the acute in the best of all possible worlds, the researchers that NIH funded would sign a compact saying, in the case of a pandemic, we're all going to be pandemic researchers, and we're going to take direction from the top down, and we're all going to do it lockstep. And then things could really move quickly. But the way it folded out, and it was quicker than anything else we ever did, but it took months to get contracts signed. There were people doing multiple different trials. Some of them NIH funded, some industry funded, some of them hospital funded. And not sure that our system is not built to respond, on a dime to get a big health problem like we got hit with. And so if we want to learn a lesson, I think we have to organize ourselves to jump into a different mode of activity in the case of a pandemic. And that would, you can't do that on the fly. You got to be ready. You got to do preparedness for that, get it all set, and hopefully you never have to trigger it. But you have to test the system, make sure it's working, have all the contracts, everybody signed on, and there's got to be a penalty if you don't play ball. So that's what a lot of the people who have been involved in the acute trials are talking about. That now is something that we should get ready to do for the next pandemic on the research side of things.
very good. Josh, you have an additional comment?
Oh, I think the other thing we also have to learn about is how to communicate our science more effectively in a public health relevant way.
Well, listen, on behalf of the many people who have listened and I'm sure learned as I have, we want to thank both of you. You're very busy people. We fully understand and appreciate very much your sharing your experience and information. And I think it's extraordinary that this is probably, it is, I think, the first pandemic, well, maybe HIV was the first in the modern era, where there's this incredible investment and combined collaborative activity, a lot of bridge building going on, not only between disciplines, but between countries, between health systems. So this has been an extraordinary presentation, and on behalf of everyone, thank you. Thank you very much.
Thanks for having us.
It's a pleasure. Thank you.